Hear the latest reporting and analysis on the big stories of the day on the Daybreak Insider podcast. It's top-notch reporting from SRN News, along with the sharpest insight from Hugh Hewitt, Mike Gallagher, Dennis Prager, Sebastian Gorka, and the voices of townhall.com. The Daybreak Insider podcast. It's your first look at today's top stories. Available at Apple Podcasts, Spotify, Google, and at SalemPodcastNetwork.com.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day. While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Yep, and that's us, and we're here at you. And by the way, this is a recorded program. But we do love when you get in touch with us and tell us what you want to hear or what you're thinking about. And we're going to do that today. Dr. Randall Juleff is the medical director of Vein Clinics of Hawaii, located on 4 islands and growing. And just a really good way to learn things. And it's at veinclinicsofhawaii.com. Today, we love lists. This is a list. It's 10 frequently asked vein questions asked by patients. And we like that. We like people get in touch. Go to the website and put a contact us on it. I would say that a lot of people find out the answer to not just one question, but plenty by listening to us.
Yeah, and just as a reminder, people can go to the website, and I believe it's on our homepage, that they will see, I believe we have a picture of you and I.
Yep.
And
doing our thing.
Just click on there. There's a link, and you can leave questions. Because I love to hear questions, from patients themselves. It really helps me kind of understand what people want to hear about, for sure.
Well, this is one that I'm sure comes up a lot. Question number 1.
Yeah.
When somebody gets either referred or has a problem or has some symptoms, this question is, are my veins blocked up?
Right.
Are they?
Well, the short answer is no.
Yeah.
But I think that question goes to a number of different things, and the first is that a lot of people don't know the difference between arteries and veins, or they'll interchange. And actually, I think that people probably know the word vein more than they know artery, because they'll often use vein if they're talking about like a blood vessel that would be the artery. So a lot of people don't know the difference, which there's no reason why people should. So arteries are the blood vessels that carry blood from the heart to the body, and then veins are the ones that carry them back. Now, they're even though they're both blood vessels, they're very different. And, they look different. They feel different. When you're operating on somebody, they, look very, very different. Arteries are a lot firmer, a lot more. There's a greater muscular, layer to the artery. Veins, in comparison, are very flimsy. You can compress them easily. Yeah. There's nowhere near as much pressure in veins as there are in arteries.
Why would somebody think they're blocked up? I mean, obviously, if you have a clot or something like that or something. But, I mean, arteries, they become constricted, right, because of plaque or whatever.
Well, and I think that's it. Yeah. Because people often confuse one with the other, and because they often use the term vein when they might mean an artery.
I'm sure of it,
and I think that most of the time when people hear about problems with blood vessels, it's because the blood vessel is blocked. Mm-hmm. When you have a heart attack, it has to do with an artery, being, blocked that goes to the heart, or the stroke.
That's what they talk about, stents and openings and
Exactly. And then so they hear about their, parents or family members or friends or whatever, went to the hospital, they had a heart attack, they put a stent to open an artery, so no, veins aren't blocked. The way that they lose their function is by losing function of little one-way valves that are inside the vein. And, veins are the blood vessels that carry blood back to the heart. So veins in our legs should be consistently moving blood upward on its way back to the heart. And when they fail in their function, the blood starts to go in the wrong direction. It goes down. And so what's happening is that those little valves are failing. Yep. And those little valves are failing. Usually it's a genetic sort of predetermined kind of thing.
What's kind of fascinating about that to me is that, when you discuss what the treatment is, is sometimes that vein will be so unable to get the blood going back uphill like it's supposed to, that you just have to figure out a different way for that blood to move.
Yeah. Often the way that we deal with that is to close the vein down.
Just close it all up.
Not only is it not blocked, but we're going to block it for you.
But that's why I thought this is fascinating, because this is not necessarily the same patient with the same question, but we can return to this blocked word. But this one says, if you close my veins, how will blood get down to my legs, to my feet in the future if the vein's not there anymore?
Right. And kind of the same misunderstanding there is that they're kind of feeling like veins are the blood vessels that carry blood down. It's not. The arteries carry the blood down, and then also the other part of that question is, my vein wasn't working, and you're going to close it down?
Yeah.
So,
wait a minute. So I got something that maybe not 100%, but now it's going to be gone? What's going to replace it?
Right. Yeah. So, so the basic premise there, why do we, the question is, why do we close veins? Why is the treatment for abnormal vein function for us to just close the vein down? And that goes to the fact that, again, the main problem there is that there are, many, many little one-way valves that keep the blood moving in the right direction in veins. And, for normal vein function, we need to have those valves functioning properly. The thing that we inherit from parents and grandparents is the propensity for those valves to fail. So could we surgically repair all of those valves? Well, I guess you could try.
I'm really glad you said that, because I know in a lot of previous shows that some of the people comment to me and say, hey, look why don't you just get new valves? Yeah. And I've known over the years that we've been talking about this is that just hasn't been worked yet. And they're so small in most of these veins that it would be hard to make a mechanical one.
Yeah. At this moment in time, with the technology that we have, now, that's just not feasible in any way, shape, or form.
But interesting that you said this when we talk about that, and that we don't have those in the arteries because you don't need them. Yeah. Because the heart is a pump, right? And it's shooting that blood up, down, wherever it needs to go. Mm-hmm. But making it turn around, there's no pump.
Right.
Yeah.
Yeah.
To speak of.
Yeah, and I think a lot of people feel that way. A lot of people think that the circulation, both arteries and veins, all of it's moving because the heart's pumping, and that's not the case at all. The heart pumps our blood through arteries, and that gets dispersed to all of our bodily tissues. Well, then once the blood goes through the arteries and then onto smaller arteries and then onto something that we call arterioles, and then it goes on to capillaries, and the capillaries are the very, very most tiny blood channels that where like maybe just one red blood cell is going through that channel individually.
Mm-hmm. Yeah,
and that's where oxygen is then coming out of the red blood cell. Then it moves into the venous side. Goes to the capillaries, then tiny little veins and venules, and onto bigger veins, and on its way back to the heart. Well, by the time it gets over into the venous system, that pressure head has been dispersed.
Gone.
Yeah, it's no longer there. So, what is it then that causes blood to move through veins? Well, mainly two things. Muscle contraction,
sure,
and then those one-way valves. So and how do they work together? Well, when our muscles are contracting, they are compressing the vein.
Yeah.
And when it compresses the vein, the blood in the vein has got to move somewhere. It's either going to go up or down.
Yeah.
Now, if those one-way valves are functioning properly, then it's going to go up.
We commonly talk about this as a leg issue.
Right.
Or a foot issue. In actual fact, the blood's going everywhere. But because we so often talk about legs and feet, mm-hmm. I'm guessing, and I know that there's been other questions in the past, that's because that's the furthest away from your heart your blood is.
Well, it's the furthest away, and also it's the lowest.
Mm-hmm.
So
that's what I meant. It's down at the bottom.
Yeah, and there's and since we spend most of our life, of our waking hours in an upright position, the blood getting from our feet and lower leg back up to the heart is the biggest job.
Yeah, longest trip.
For instance, the blood in the upper part of our body or upper extremities in our head. Most of that blood is moving because of gravity. It's just kind of falling back down into the heart. So it's not as reliant on one-way valves, although there are one-way valves in those veins too. And might some of them fail? Well, probably they do, but it's just it doesn't become a pathologic problem. But in our legs, the valves are so important that when they fail, it creates problems in blood flow through veins, and thereby then leads to symptoms.
Okay, now that's where question number 3 comes up. And then question number 3, and I'm guessing that somebody that's listened to our show or somebody that's had symptoms and been looked at, this is a great question. And, since we are a world of procrastinators, this sounds like that to me. But I guess you have to weigh the thought of this question and then the answer. So, and remember, Dr. Randall Juleff is medical director of VeinClinicsOfHawaii.com, and you can submit your question too. This one is, can I put treatment off, or do I need to do it right away?
Mm-hmm. We hear that question for sure. Very rarely is venous intervention urgent, especially when we're talking.
There are a few exceptions, which I know you're going to cover it a little bit here.
Yeah, there are definitely a few exceptions. But for run-of-the-mill garden variety venous, insufficiency that we're seeing in the office day in and day out, is it ever an emergency? By and large, no. Mm-hmm. So, can we kind of fit it into somebody's schedule? Yes. Mm-hmm. Now, why do we choose to treat somebody? That's sort of part of this question too.
Mm-hmm. Yeah.
Mainly the thing that directs us into how urgently or how aggressively we feel like we should treat somebody is their symptoms. Mm-hmm. And so people come to us for a reason. They have either big varicose veins or superficial veins that they see. And when they see those things, it's easy for those people to say, mm-hmm. "Gee, I have a vein problem." But there's a whole variety of other symptoms that people have that are related to, this thing that we call venous insufficiency, and and sometimes they don't know specifically. They have some. They have complaints about their legs, just in general.
Yeah, and that's what I hear a lot. As a matter of fact, gang, one of the things that this is, if you decide to take some action here, when you visit Vein Clinics of Hawaii, you're given an iPad, and there's a pretty thorough questionnaire that you
Right.
ask
Yeah.
to sort of categorize, not if somebody has it necessarily, because by the time they get to your office, they probably have something wrong with their veins.
Typically they do.
But what's the severity and what's the learning curve, and where are they in the 6 or 7 different stages
Right.
of venous disease? That's going to indicate when you need to do your treatment.
Yeah. And yeah, sometimes people get frustrated with our iPads.
Yeah.
And
They're not that bad.
Because there's a lot of questions there. But yeah, there is some reason to our madness, and that is that a lot of symptoms people have, and they don't think about it. They don't think about the fact that this might be due to poor vein function.
Yeah, exactly. It's just my leg is heavy. It's just I got weak muscles
or achiness. Muscle ache and leg. General achiness of the legs, and because a lot of people will chalk it up to age. I can't tell you how many times I've heard. I'm
getting old. That's why.
Yeah. Or they'll chalk it up to other reasons. But often, often there's a kind of a reason why people are having all of those symptoms in general, and venous insufficiency is often the thing. So we assess the symptoms that they're having and the severity of their symptoms, and really the bottom line with respect to all of that is how interfering are those symptoms to your daily activities? What are you not able to do on a day-to-day basis that you'd like to be able to do, but you have these symptoms and you feel like you can't.
Yeah, and that's gang, where we're really trying to stop this. And so that's why you got to think about it. And by the way, as Dr. Juleff mentioned, you go to veinclinicsforhawaii.com and see the website. There's also a lot of different types of things shown to you, and you may not even think that it was venous until you go to the website and see it. But one of the things that we talk about all the time, and I'm pretty sure why I think this question number 4 of our top 10 is that you talk about the way they used to strip veins and the way you now go ahead and make a vein, you discontinue its use, but you leave it in there. It's nowhere near as invasive. Everybody asks this, and I know I did when I was first a patient, is if I have all of this treatment and you're removing all these bad veins from my legs or making them so they don't work any good, is there a time when I'm going to run out of them and I'm not going to have circulation because I don't have enough veins?
Right. Yeah, we hear that too. But you know what, Mike, getting back to the last question,
sure.
There was one more thing that I wanted to add, which I think is important. With respect to that question of, do I have to do it now or can I put it off? But, there's 3 reasons why we treat venous insufficiency.
Okay.
The first is to treat the symptoms. And that's where we now get into, assessing symptoms. What do they have and how impactful are they to their day-to-day living? So, number one, do we want to relieve symptoms? Second reason that we treat venous insufficiency is because the natural history of venous insufficiency is that it only gets worse with time. So
it will get worse.
Yeah, it will get worse with time. So maybe now, rather than waiting for 10 years from now, there may be reasons why you want to go through these procedures now.
One of which, gang, for me and for many of us, is not just quality of life, but ability to earn an income and work.
Sure.
And, if you have venous issues that you don't treat, your days can be pretty miserable. And nobody wants to, go home and flop in front of the TV because they're too tired to walk around with kids.
Yeah. Yeah, and we've had patients say that they, they were really unable to fulfill their work duties, for instance. And, this day and age when people need to have an income a little longer into their, senior years.
Or a second or third job, you bet.
Yeah, that it becomes even more important. So number 2, because it only gets worse with time. Number 3, because people with venous insufficiency are at a higher risk of developing a DVT blood clot.
Okay.
And the risk,
bad guy.
The risk is about 5 times higher than the normal population that do not have venous insufficiency. So, DVT blood clot is something that not only can be tremendously detrimental to the function of an extremity, it can also be fatal. So those are the three reasons why we treat it. And so usually when people come in and they have that question, if they've come into our office for whatever reason, we've done the ultrasound and we see that they have what we would refer to as significant venous insufficiency. Then often I go through those three things, and then the patient can decide for themselves.
Weigh the pain and the gain. That's kind of what I did. I was very reluctant for a long time to get, that's no big deal. Who cares what they look like?
Right.
But it wasn't what they looked like. It was, why can't I walk around late at night because I'm too tired because my legs hurt?
Right, right, exactly. So anyway, the question about will I run out of veins at some point, and that's also, a very common question that we run into.
Misunderstanding.
And the basic answer there is no, you won't. And that kind of goes to our second question. Why are you blocking? Why are you eliminating the flow? Am I going to be okay with you eliminating the flow? And the answer is you'll actually be better off for it. But I often tell people that the venous system, not only within our body, not only within our legs, but our entire body. If you were to remove everything else and just look at the venous system, it's really like a tree root, where the main vein is the trunk, and there's just levels, multiple levels of different sized vein branches, et cetera. So, when one vein is not functioning properly, when one vein is actually working against you and, making your circulation worse than it should be, and we close that vein down, the body just naturally reroutes the blood.
It's amazing, gang. And that's what Doc says all the time. It's taken me a long time to figure it out, but it's like the guy in the office makes the decision. Okay, I know you used to go up plan B, but now you're going to go on plan A, or I'm going to make a new one. It's simple. I mean,
it's easy.
So the answer is no. You never run out of it.
Yeah, right. And a lot of people will say, "Gee, well, okay, so you're going to close down this vein, and I'm going to grow a new one." And typically, no, that doesn't happen either. But again, the blood gets rerouted. It happens automatically. Which is also another thing that people ask. They say, "Gee, it's going to," because I'll say, we're going to close the vein, and your body's going to reroute that blood. And then they say, "Well, what do you have to do to make it reroute?"
Yeah, but what I found out really, really interesting. One guy said, "It's like when you prune a tree, and you cut a tree, it all of a sudden starts blossoming."
Yeah,
and so that's what's happening is you'll see new little shoots coming up because the old one was dead and dried up. It had black fly on it or whatever. And now here comes new flowers. Go figure.
Yeah. So it's new flow. And, and it, just another example of how miraculous our body is. And, closing veins down because they're not working, we have found, obviously, over the course of, whatever number of years that is a beneficial event.
Okay. Now, I know this next question. It's number 5 on our list of 10 frequently asked questions. And by the way, you can ask your own. If you go to the website, veinclinicsofhawaii.com, you're going to see Doc Juleff and me, and you're going to have a way to click into a question for us. I love this one because this is like me and before. But it wasn't a wife. It was just me. But this says, my husband has all these problems, and they're probably worse than mine. What do I need to tell him to make him want to come in and see you? He says they're not bothering him very much.
Very much. Yeah, key word there.
That is a key word right there.
Yeah, very much. So again, this kind of person, we just, I encourage them, through their spouse, to come in and just talk to us. Just because somebody comes in and talks to us, it's not like we're going to tie them down and force them to do anything that they don't want to do. But, it really just has to do with, communicating with that person, and going through all the stuff that we've already talked about. Do you have symptoms in your legs? Do you have achiness that kind of worsens over the course of the day? Do you have heaviness and fatigue that worsens over the course of the day? And, for people, I think she sort of alludes to the fact that, the husband had varicose veins. And anybody with varicose veins is nearly 100%. They will have venous insufficiency. Varicose veins are the superficial sign that there's a problem with the veins that are deeper in the leg. And so, very rarely do people have varicose veins and also the accompanying venous insufficiency and not have symptoms.
Okay.
I think
because it has to bother you somehow.
Yeah. And so I think that the thing that I like to talk to people about is to try to find out if they are having symptoms, but they're chalking them up to other reasons, And again, age is a very easy one for people to chalk symptoms up to, and we hear that all the time, where people come in and we'll talk about their symptoms, and we ultimately treat them, and then after they're treated and after they've recovered and healed, they come back. And invariably they say, gee, doc, I didn't know how bad my legs really felt. Because now they feel great. They feel light and energetic, and, my whole body just feels better. So that's what I like to talk to the reluctant patient. Those are the things that I like to talk to them about. What's really going on with your legs, and might we attribute that to something other than just aging or diabetes or whatever, and can we do things to make you feel better?
And I'm glad you said that, because there's two prongs here. One of them is if you have symptoms that bother you at work, and like we've said in previous discussions, people have got to work longer now and work harder, and if it's diminishing returns. But isn't the other one to say, well, I used to go and walk around the block at night after dinner, and I haven't done that for a couple of years because my legs hurt.
Right. Yeah.
That's quality of life, not just making money.
Absolutely. So, and then also, I go into discussion about, why we treat, those three things that we talked about a minute ago. So usually if they just come into the office, we can kind of have that kind of conversation, and it makes a lot of sense to people when we talk to them and explain those things to them, and especially if they then have an ultrasound.
Sure.
And we kind of our vascular techs kind of try to show people what they're seeing.
Here's what's going on inside your leg. In your veins.
And not only is there a picture, but there's kind of noises that we look at, and then that's when that's when the understanding really kind of starts to sink in, and I think just giving people all of that knowledge, and then again, at the end of the day, it's going to be their decision. It's not like we're going to force them to do anything. But and that's why I often encourage people. Sometimes people will call the office and not know whether they should come in or not.
Sure.
Either they have problems that, again, they don't know are specifically related to venous insufficiency, which happens all the time. We certainly encourage those people to come in, but even those people who have symptoms that might not be related to venous insufficiency, at least we can help them sort it out.
Yeah, and that's why the great referral systems work with primary care doctors, with gynecologists, with everybody, and it also gets that the profession looks at different specialties like yours as having a specific go-to kind of person to do it.
Right.
And I remember you on a previous program talking about the difference between a dermatologist and a venous surgeon or a venous doctor looking at rashes or problems with the legs.
Yeah.
Because the patient has no idea.
No.
What is this? Whose fault is this? Who can I see?
Yeah. Well, And yeah, that's a prime example of how diverse the symptoms of venous insufficiency can be, because a rashy kind of problem with the skin of the lower leg is a very, very common problem associated with venous insufficiency. We call that venous eczema, and it can look like eczema. So many of those people have been going to a dermatologist, and maybe they're not getting the relief that they thought they should, so they start to look around. Or they go to the dermatologist, and the dermatologist recognizes that, hey, this is not primarily a skin problem, it's primarily a circulation problem, so they'll refer them to us. It's kind of a double-edged sword.
Yeah.
It keeps things very, very interesting, but also confusing for many lay people because they don't know the symptoms.
But I looked at it personally, like each condition you are able to mark off the list gets you closer to what's really going on.
Right. Yeah. If they don't have venous
Yeah.
disease, then maybe it's an arterial problem. Yeah. Well, we can diagnose that for them. Or if it's if we look at their circulation, arterial and venous, and both of those are fine, then maybe it's a musculoskeletal problem, or maybe it's a neurogenic problem. But we can help get those people to other physicians that will be able to help them.
Yeah, and that's why that's why it has the iPad in there. So a lot of this can get parsed out right away, and by process of elimination, find out what's wrong with you and where you should be treated. Now, this next question, I really like this one because we've talked before about it, the ratio of men and women that get varicose venous insufficiency, and it's about 50-50. But because women are slightly more prone to have it because of this very question that this lady writes. I'm a 35-year-old mother of 2 kids and might want to have more children. Should I wait to be treated when I'm done having kids?
Right. Yeah.
I know you hear that a lot.
Yeah, we do.
Aren't there also times during the pregnancy where you won't do treatment?
Well, we don't really do anything to a lady who is pregnant. So that's kind of across the board. Mm-hmm. But there's 2 scenarios there. The first is specifically what this lady is asking. I might have another child. Should I be treated now? I've got varicose veins, and I've got pain and swelling, and et cetera, et cetera. For the most part, across the board, I'll say, you probably should be treated, because of the fact that we can kind of halt the process right now. Mm-hmm. And it'll make that upcoming pregnancy, if you have another
maybe
pregnancy,
more tolerable,
much more tolerable.
What a relief
much
it is!
More tolerable. Because when women have venous insufficiency and they are pregnant, it can not only can it be that much more uncomfortable, but you can have complications. You can have venous thrombosis and all this sort of thing. So, there's any number of reasons why it would be beneficial to treat that. And then secondly, and this is what I tell people, the problems that we're going to treat are, the things that we're going to treat are the problems that you have right now, obviously.
Sure.
So are those treatments going to withstand the process or the stress of going through another pregnancy? Well, yeah, they should. The procedures that we do for venous insufficiency are very reliable and very durable. Mm-hmm. 95% of the time, the long-term success is high. They should be able to go through a pregnancy and not affect the treatment that they've had.
That's good.
Yeah.
And by the way, another question I just thought of springboards into that a little bit. Is that groin area and that torso area where most of the business is going on? It's in the middle between your heart and your feet. And I know for women that they take dramatic changes in that part of their body. Does that irritate or magnify venous problems?
Yeah, well, it does for sure. Part of the thing that's going on during pregnancy is as the uterus is becoming enlarged, it's exerting pressure or impacting the large pelvic veins, and those are the large veins that go down into the legs. So it's really kind of impacting flow of venous flow out of the legs at a very high level. So that's a problem. And then there are other things. The hormonal milieu of pregnancy kind of lends itself to developing venous dilatation and problems that go along with it.
Yeah, everybody's heard, oh, my aching back, oh my, and it's true. I mean, I we can't give women enough credit for what they do to that.
Yeah.
And, right after delivery, thinking, well, you going to have any more babies? Don't talk to me about babies right now. It's a tough deal, isn't it? Yeah.
So then the other scenario that we see a lot is that we might see a woman who has been wanting to come in to see us, and things have gotten in the way, and they might have varicose veins, and they may have symptoms of venous insufficiency, and then they get pregnant again, and so they may be in the very early stages of pregnancy, and they come to see us for the first time, or they're wondering whether they should.
I see
gee,
that.
I got pregnant. Maybe I shouldn't even worry about coming in. Well, I say no. You should come in, because we're not going to do anything. We may or may not even do an ultrasound because we're probably going to want to wait till after that pregnancy. It kind of depends on how far along they are. But it would be good for them to come in. That way we can make sure that they have, all the information they need with respect to compression stocking use.
Sure.
And we kind of get them into our system so that we can assist them if they have any concerns over the course of their pregnancy, and then we will be, kind of ready to treat them once they deliver and they've gotten over all of that process.
Yeah, so like I said, ladies, so much to your credit in that area. Oh, my goodness.
Yeah.
Interestingly enough, as we move along, and by the way, Dr. Randall Juleff is the medical director of Vein Clinics of Hawaii, and you can find us on the web at veinclinicsofhawaii.com, and you can click on the area where Doc and I are there on the website and learn about a lot of our shows and see a lot of really great stuff. A lot of work is being done to make it a user-friendly. So this is kind of interesting because we go from this 35-year-old mother too, and the next question in between bookmark into a lady who's 70. That's going to come up in a bit. But this always comes up, and I know there's been such dramatic change in your profession over the last 20 or 30 years that it's no wonder that people ask this question, but the answer is not like it used to be, and that is the 5 big words you hear all the time. Is it going to hurt?
Yeah. Yeah, I think that's a huge deterrent to many people.
Yeah. Yes, I'm out of here.
Yeah. So, and I mean, we hear that question multiple times a day, and people will say, "Gee, doctor, is it going to hurt?" And invariably, my answer is, "Well, it's not going to hurt me a bit, but I thank you for asking." But
that's his comical contribution of the show.
Yeah. So, but it's nothing like it used to be. And we do everything that we can to keep it as comfortable as we possibly can. And by and large, I think we do a decent job at that.
Let me tell you, gang, I've had treatment, and the equipment that is being used now, it's like if you go into a day where they used to take out teeth with the pliers, the needles and these things they use are so small, and under the guidance of your hands, it is way less invasive than it ever was before.
Yeah. And actually, the other thing that I used to say is that a lady asked me, "Is it going to hurt?" And I said, "Well, no. I mean, there's not that much discomfort." And I said, "It's no worse than going to the dentist." And she looked at me with wide eyes and she said, "I hate going to the dentist." since then I've stopped using that comparison. But actually, what I tell people is it's not as bad as going to the dentist. So but yeah, you're right. I mean, we use a lot of numbing medication, and we use something that we call tumescent anesthesia. And that's just a fancy word that indicates that we inject a lot of this numbing medication, which is a very dilute numbing medication. Yeah. We use a numbing medication called lidocaine. That's similar to what you do get at the dentist, which is called Novocaine. They're they're similar but a little different. So we use we use a tumescent anesthesia. We inject it, but we start, like you alluded to. We start with a tiny needle. The first area,
so little you can't believe it.
The first area that we numb is we use what's referred to as a 32 gauge needle. It's tiny. It's the size of the needle that you use to get Botox.
Let me tell you the thing that I find fascinating about that, and I saw it in your office. I just can't imagine how the tooling is that you can take this tiny little thing and make a hole down the middle of it. I just don't get it because It's so small to begin with. You think, okay, it's got a wall over it, and it's got something. How does stuff get through there? You see a drop of water, and you see this needle, and it's like 1,000 drops of water.
Yeah,
it's 1,000th of what you're doing.
Yeah,
amazing.
Yeah, it is. So we start the numbing process with a very, very tiny needle, and then we kind of go. We skip from one point to the other, and we numb an area, and then we use that to kind of get to another area. So again, we keep it very, very comfortable. And we offer to call in Valium or whatever kind of anti-anxiety kind of medication that people want. And, it's surprising the number of people that don't even use that.
Yeah, and I haven't. The last couple of treatments I haven't, just because I wanted doing this show and talking to people. I mean, I'm telling you, every now and again there's a little pinch, but what at the end of the day, you walk out of there like you walked in. Yeah. And it's an hour. You've been in there an hour and a half maximum, you're out of there. Yeah. Where it used to be when I visited my mom in the hospital, when she had her varicose veins done and legs stripped, and everything, hospital for 2, 3, 4 days, and then at home for a week.
Right,
and
right.
You're talking to me outside of going swimming this afternoon. I go back to work tomorrow.
Yeah. So, I think most people are pleasantly surprised at the lack of discomfort that they do have during the procedure. Yeah. And then the other thing that I find is that, people, so we use all this numbing medication, and people can tell that their leg is very numb, by the end of the procedure. And so they, often they'll ask, gee, how long is the numbing going to last?
And is it going to hurt when the numbing goes away?
Yeah, that's the next question. and I think, pretty much across the board, people are, pleasantly surprised that even after that numbing medication wears off, they really don't have that much discomfort.
Yeah, not to disparage dentists, because we have a lot of friends that are dentists, and mine in particular. That when that pain medicine wears away, most of the time, because you've had something pretty traumatic done, whether it's a tooth being pulled or drilled or changed, there's gonna be a little happy pill that you might have to take when you get home.
You're gonna feel that for sure. Yeah. So that's where we differ from dentists, and again, I think it's much more comfortable.
Okay, question number 8. Like I said, we had one sandwich. We had the 35-year-old mother of 2 that want to have more kids. Here's one that says, my mother is 70 years old and has had bad varicose veins. She thinks she's too old to worry about it. What should I tell her?
She should tell her that she should come into the office immediately.
Yeah, seriously. Quality of life we're talking about here.
Yeah. We do procedures on 70 whatever odd years old all the time. It's amazing. Not only is, venous disease kind of an equal opportunity employer for, the genders, male versus female, but it really attacks all age groups too. We're actually just this past week we've been treating a young male, early 20s, He has a very strong family history, but he had bad venous insufficiency, a bunch of varicose veins. But we've treated people as young as 16.
Yeah.
Again, really bad family history, and bad varicose veins, and we've treated. I think it was just a few months ago that we treated sort of our the higher limit. I think we treated a 95-year-old man here recently, and he did fine. Now, it all depends on the basic general medical condition of the patient, but just age alone is not a deterrent. And again, I mean, we treat 70-year-olds all the time. We treat 80-year-olds all the time.
Well, you know what? I think, gang, for those of you that are listening, the fact of the matter is we're outliving our stuff. And so, whereas you may 30 years ago, somebody that was 70 probably not going to go to the doctor.
Yeah, maybe at the end of their life span.
But now look, the 70 is the new 50.
Oh, absolutely.
And so there are people that are, and so you talk about teeth, you talk about eyes, you talk about hearing, and you talk about veins.
Right.
Those are the things that we're kind of outlasting.
Yeah. And symptoms from those things can impact their quality of life for sure. I can't tell you the number of older people who have muscle cramping as a symptom.
Yeah.
And, muscle cramping can be a very solid symptom for venous insufficiency. And it seems like that older age group, they really, really can be impacted by muscle cramping in the middle of the night.
I was going to say quality of sleep or cramping and waking up with a horrific pain.
Right.
Yeah.
And some of them, wake up with muscle cramping, and it might take them, an hour or more to get that muscle cramping to relief. Ugh. And, sooner or later, that's going to impact your general quality of life. Any number of those types of things. And we can improve that with very simple, in-office, minimally invasive, easy to recover from, procedures that really will be beneficial for, a lady of 70 years old, probably another 20 years.
Are you, I already know the answer to this too, but I need to throw it in there. And I do know that when somebody comes back for a checkup, or comes back 6 months later, you must hear some incredibly interesting comments about, holy smokes, I should have done that 10 years ago because I sleep like a baby. I don't have cramps anymore. I can point my toes and pump my legs and not feel that I'm going to get, into some sort of spasm or something.
Right. Yeah, we hear those kind of comments all the time. It makes our job so rewarding when we hear that kind of stuff, for sure.
Now, there's one, we actually talked about this a little bit earlier. This is number 9 of 10. And this is interesting. I am a diabetic and from time to time have had cuts on my feet that turn into ulcers. Am I at risk for venous ulcers as well? And if so, what's the best treatment for them?
Yeah.
What's the difference between a venous ulcer and a diabetic ulcer?
Yeah. Well, they are very different, and typically you can just kind of look at them. There's several different broad categories of ulcers of the lower extremity feet. Either it's an arterial ulcer, which has to do with the lack of blood flow down. Or it's a venous ulcer, which has to do with the lack of blood flow going back up. Or it's a diabetic ulcer. And a diabetic ulcer is, we refer to that as a neuropathic ulcer, but, it has to do with the microcirculation, et cetera, et cetera. But so physiologically, it's a little different process. Diabetic ulcers are often, on the bottom of the feet. We call them sort of punched out, appearance, which means it's, just kind of a small round, defect of the skin. And
that's what ulcer is, gang. It's a hole.
Yeah. And whereas venous ulceration is usually ankle level or higher. The venous stasis ulcers tend to be flat. They tend to be a little larger. They have sort of an irregular border. And they have kind of often a beefy kind of appearance. Arterial ulcers are usually more further down into the foot, the tips of the toes. The areas where the blood is going to have the least opportunity to get to.
Isn't it also interesting, Doc, that a lot of these injuries to diabetics or a lot of these ulcers start from a little hole that they didn't even feel.
Yeah,
right. A little different, isn't it?
Right.
Yeah.
So, this particular question, they're diabetic, and if they develop little nicks or little injuries on their feet and lower legs. Well, the answer is it could be a problem. It could be either a problem with their diabetes or it could be a problem with venous insufficiency.
Are you sometimes amazed at how bad some people will let something get before they show up at the office?
Yeah, sure.
I'm shocked.
For sure.
Yeah.
Especially with venous stasis ulcers, some people come in and they've been, kind of doing the home remedy thing for, a year and a half or something.
Yeah.
And
I don't mean to laugh, but I mean, it's like the definition of insanity. You put that antibiotic treatment on it every day and a new Band-Aid every day, and you do that till you run out of Band-Aids 5 or 6 times. You haven't got the right, you don't know what's happening.
Yeah. And that kind of goes back to the fact that, most people who have venous stasis ulcers, they have no idea what it's due to. They have no idea that it would be due to poor vein function. So they don't know that, and that's just a knowledge problem. It's not anything more than that. And again, that's why we like to talk about this stuff. But so that particular patient. Could people have diabetes and venous insufficiency? Oh yeah, for sure.
Yeah.
But I one thing that I can say is that people will often chalk up problems with their legs. For instance, chronic swelling, skin discoloration, problems with skin, the rashy kind of things, people who are diabetic will often chalk those things up to their diabetes. And, often it's not due to their diabetes. It's due to underlying venous insufficiency.
It was.
So,
the perfect storm going on in two places,
So, do we treat people with diabetes? Yeah, all the time, for sure. So,
okay. And that's what's important about that is that you're still going to see your diabetic doctor. I mean, you just have more than one thing going on. But isn't it a relief when people can differentiate between what's what?
Oh yeah, we have to differentiate between those reasons for ulceration because then we have to treat them a little more in a more directed fashion.
Okay, question number 10, and this is the final one in our 10 frequently asked questions asked by patients. We've talked about this a little bit. It says, as I become older, what can I do to prevent additional varicose vein problems from happening? That's a real tough one, isn't it? Yeah, because is there a way to prevent them from happening, or is what it is?
Well, it kind of depends on what the status of that patient. For instance, patients who have come in, they have gone through the process. We've treated them for their venous insufficiency, and then once we've completed their treatment plan, et cetera, then the question always is, what do I need to do from here?
Yeah.
To limit the possibility of having further problems in the future. And, and by and large, the mainstay of that is compression stockings. And I encourage just about everybody who has had, venous treatment to incorporate some use of a compression stocking in their day-to-day life to the extent that is comparable to the symptoms that they're having and may have on an ongoing basis. And
let me tell you, if this was TV, you could see me grinning because I just got another couple of pairs of these, and I know they're a pain in the you-know-what, but I've been wearing them for years, and I've developed a little trick of getting them on and getting them off, and they make a huge difference.
Right.
Yeah, I mean, they really do. They make you, especially those of you that are standing for a living. I want to tell you, if you wear these things, and Doc, you wear them, and a lot of your staff wear them, and they're not obese and they're not, symptomatic. They just feel good.
Oh yeah. I've been wearing knee-high compression stockings for a long time. So people who have been treated, definitely compression stockings, and then we may periodically do what we refer to as surveillance ultrasounds. Mm-hmm. So, and we have a process by which we call in 6 months. We call the patient. We say, "Hey, how you doing?" And
any symptoms, any increased blood?
Yeah, exactly. Yeah. And if they have any concerns, we bring them in for an ultrasound. Yeah. Compression, elevation when they can. Periodic ultrasound, that's going to help the people that we have treated. For those people who have not been treated, maybe have not had venous insufficiency in the past, compression is always a good thing, and usually in most people are going to benefit from that, especially those people who work on their feet.
Well, there you go. The 10 frequently asked questions. You can see them online. Later on, they're going to be up there at veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. Thank you for listening. Tell your friends, and don't be afraid to go to that website and give us a call and tell us what you want to hear on the show and get yourself taken care of, because it will make a huge difference. And that, my friends, is a guarantee. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.